So now we'll look at a very important but often overlooked topic in our textbook, which is the endocrine changes occurring in pregnancy. We have learned about these endocrine changes in pregnancy, bits and pieces along with the individual modules, but here I'll be giving you a consolidated view on the topic. Now first about the placental development in a newly fertilized egg. So after fertilization, the initial 4 to 5 days following fertilization, the fertilized ovum or the newly formed zygote lies in the fallopian tube up to 5 days. And this will stay in the fallopian tube till 8-celled or sometimes 16-celled stage. So 16-cell stage is what we call as morula, and still that time it is still there in the fallopian tube. And this zygote enters the uterus at the around day 5 to 6 in 16-cell state, and that is when the process of implantation starts to happen. So the implantation occurs between day 6 and 9 post-fertilization. Post-fertilization day 6 to 9 is when the implantation is occurring, and at that time the fertilized ovum or the zygote has got two distinct areas, which is the inner cell mass and the trough ectoderm. Of these, the inner cell mass later develops into the fetus and trough ectoderm develops into the placenta. So that is when the implantation occurs. And this trough ectoderm later further divided into cytotrophoblast and syncytiotrophoblast. Now, the mother to fetus hormonal transfer depends on various factors like the placental blood flow, what is the resistance of the blood vessels, then what is the amount of free hormone concentration, whether it is in the bound form or free form, because the bound form is less likely to be transferred onto the fetus, and most importantly about the molecular weight. Those hormones with a molecular weight of less than 700 Dalton is freely transferred, and those with a molecular weight more than 1200 Dalton is impermeable. And between 700 to 1200, it depends on various factors like the charge, the repulsion and everything. So less than 700, there is free transfer across the maternofetal membranes, and more than 1200, it is impermeable. Now, this placenta, as you know, is a major endocrine organ. It carries out endocrine function and produces lots and lots of hormones. So this table summarizes the different placental products. It starts from the hypothalamic analogues. They produces the hormones which are usually produced by the native pituitary, lot of steroid hormones and lot of other cytokines and other growth factors are also produced by placenta. And in fact, if you look at almost all the hormones which can be produced by a human body is produced by the placenta, if you closely look at that. Now, what do you mean by fetal origin of adult disease? It is also short term as FOAD or DOHAD. It is a developmental origin of health and adult diseases, which is a DOHAD or the FOAD. And this hypothesis was first put forth by David Barker, or it is called as Barker hypothesis. So it means that in a person, in a child or in a fetus with adverse in utero environment, which has resulted in IUGR, such individuals have high risk of developing metabolic diseases when they grow into adult. Increased risk of metabolic disease in adult. So that in the nutshell, it means that those children who were IUGR or were having adverse in utero environment while they were growing up inside the uterus, they are more likely to have adverse metabolic diseases or consequences in their future adult life. So in utero malnutrition, it causes so many changes. Like when there is malnutrition in utero, the body will try to give adequate fuel, that is glucose, to the brain So what happens is that usually this glucose in the fetus will be utilized by so many organs, the brain, the liver, not pancreas, the muscle, adipose tissue. So many other organs utilize this glucose. But in utero malnutrition, the fetal body has got limited supply of glucose. So they would preferentially want to divert this glucose to the brain, because brain is deemed as the most important organ of the developing fetus. So they would preferentially channel this glucose to the brain. And how are they going to do that? By inducing insulin resistance in other organs like muscle, adipose tissue, liver, etc. So when there is insulin resistance, they cannot utilize the insulin mediated glucose utilization is not happening. Thereby all this glucose is channeled towards this brain. So once the child is born and this adverse circumstance is resolved, and in the future when there is nutrient excess, is as with obesity or overweight situation, this insulin resistance which originated during the in utero period could still be persisting in that child. Those genes must have undergone already some change, mostly in the epigenetic form, that determines the expression of those genes, that has already undergone a change, and this insulin resistance which was there in the in utero period would still persist. And that is why when they are again subjected to a state of nutrient excess, as in obesity or overweight state, they would develop metabolic complications in the form of diabetes, systemic hypertension, dyslipidemia, etc. So that is the basis of this fetal origin of adult disease. Now coming to the usual weight gain pattern in a normal pregnancy, you can see that this is the range of weight gain allowed in a pregnancy. In an underweight woman, the advised weight gain is around 12.5 to 18 kg throughout the entire pregnancy. So the cumulative weight gain should be around 18 kg. Woman who was underweight prior to pregnancy. Normal weight, the pregnancy, the weight gain, the permissible weight gain range is between 11.5 and 16. So this has been asked previously also. So 11.5 to 16 in normal pregnancy. In overweight, it is 7 to 11.5, and obese it is 5 to 9. So previously when the question was asked, the options were given in pounds. So you can also learn it as 28 to 40, 25 to 35, 12, 15 to 25 and 11 to 20 in underweight, normal weight, overweight and obese respectively. Now coming to placental hormone production, we have learned about all these processes during my adrenal module. So in the fetal adrenal, you can see here the cholesterol is the precursor. By the series of reactions that we have already learned, this DHEAs will be formed. The 17-hydroxypregnenolone will be acted upon by the 17-20 lyase to form DHEA, and it will be acted upon by sulfotransferase to produce DHEAs. So as we know, DHEAs is the major adrenal hormone which is present in fetal circulation, and this DHEAs present in the fetal adrenal is released into the circulation and it reaches the liver, the fetal liver. In the fetal liver, it is converted to 16-hydroxy-DHEAs. So this 16-hydroxy-DHEAs, it diffuses into the placenta, and this 16-hydroxy-DHEAs is converted to 16-hydroxyandrostenedione, 16-hydroxytestosterone, and finally it is converted to estriol. So estriol is the major circulatory estrogen during pregnancy, and so that is the fate of DHEAs. So you must have wondered why the body is producing, for the fetal body is producing so much of DHEAs in utero. So it is for maintenance of pregnancy. For maintaining pregnancy, you need to have adequate amount of estrogen, and the estrogen is produced at the placenta, and the substrate for this estrogen production is the 16-hydroxy-DHEAs, which is produced in the fetal liver, which diffuses onto the placenta, and by a series of reaction in the placenta, it is eventually converted to the physiological estrogen form in pregnancy, which is estriol. You know, estradiol is the most abundant circulating estrogen form in a reproductive age group woman, and during pregnancy, it is the estriol. Now, the enzyme which is lacking in placenta is the 17-hydroxylase. So, all the other enzymes are present in placenta and the 17 hydroxylase enzyme is not there. That is why, because if the 17 hydroxylase is absent, then the androgen synthesis is not occurring. That is why the placenta is not able to synthesize this estrogen on its own. It requires the substrate in the form of DHEase. The DHEase is produced in the fetal adrenal, reaches the fetal liver, and then is transmitted to the placenta, where it carries out the further reactions. And the major secretory product of placenta is the estriol. Estriol, then also progesterone. The initial steps up to progesterone is also occurring in placenta, like the cholesterol is there, the side chain cleavage enzyme is there, 3-beta HSD is there. So because 3-beta HSD is there, the placenta is able to produce progesterone, and the estrogen is produced from the DHEase, which diffuses from the fetal circulation. Now, the changes occurring to individual glands in the mother during pregnancy. First, we'll deal with pituitary gland. You know that the normal pituitary gland size is around, the weight is around 600 milligrams, and during pregnancy there is increase in weight of the pituitary gland. It increases to around 1 gram. And as you know, as per the Elster's rule, the height of the pituitary gland also increases to around 10 to 12 millimeters. The height also increases to around 10 to 12 millimeters. And what happens to individual cell lines during pregnancy? The lactotrophs number increases manifold. The thyrotrophs and corticotrophs remains the same. There is no change. The gonadotrophs and somatotrophs, they reduce. Arginine vasopressin production, or the posterior pituitary size, also reduces. So there is significant increase in the lactotrophs. The thyrotrophs and corticotrophs remain the same. Gonadotrophs and somatotrophs reduce in number. Now, specifically moving on to prolactin, you know that the prolactin level in a reproductive age female is less than 25 nanogram per ml, with slight perturbations as per the peak as well as the nadir values. But the levels increases more than 10-fold during pregnancy, so that the mean prolactin values would be around 200 to 250 nanogram per ml. It increases more than 10-fold compared to the non-pregnant female. And when will it normalize after delivery? In women who are not nursing, it normalizes by 7 days. For non-lactating women, it would normalize by 7 days. In lactating women, it normalizes by 6 to 8 weeks. But again, during each episode of lactation, again there would be a burst of prolactin. But in between, the prolactin level comes back to normal. Now, management of prolactinoma in pregnancy, we have dealt in detail in the pituitary module on hyperprolactinemia. Microprolactinoma, you can safely stop the dopamine agonist, and macroprolactinoma, if there is no risk of impending visual field defect or mass effect, you can stop bromocriptine or cabergoline, and you can continuously follow up throughout pregnancy with monthly visual field checking and actively asking for the presence of any mass effect. And if the patient develops any mass effect or visual field disturbances, you can start dopamine agonist, either bromocriptine or cabergoline during pregnancy. And also the MRI with contrast is contraindicated. If at all you need to take an imaging, CT is contraindicated. MRI with contrast is also contraindicated. Only plain MRI is taken during pregnancy. Now, what happens to growth hormone? You know that the growth hormone has different isoforms, and the most common circulating isoform in a non-pregnant individual is the 22 kilodalton form, which is produced from the pituitary. Also, you may have a 20 kilodalton form. 22 is much more common than 20 kilodalton. But during pregnancy, there is an additional placental GH, which is called as GH variant of placenta, GHV. And it becomes the most abundant circulating form of GH by second trimester. So, from second trimester onwards, the pituitary GH levels decrease. So that at term, 85% of GH activity is from the placental variant, 12% from human placental lactogen, which also has got a growth hormone like activity, and only 3% is from the pituitary GH or the GHN. The pituitary GH is called as GHN and the placental GH is called as GHV. So that is what is happening during pregnancy to the GH axis. And what happens to IGF-1? There is antagonistic effect on the IGF-1. One is that this GHV, the higher concentration of the circulating GH will increase IGF-1 generation, but high estrogen concentration during pregnancy would partially reduce IGF-1. But net effect is increased IGF-1. So there are factors that can increase as well as reduced IGF-1 in pregnancy. The growth hormone variant which increases so much during pregnancy, it stimulates IGF-1 production, but the estrogen concentration which is increasing during pregnancy act at the level of liver to reduce the growth hormone induced IGF-1 secretion. But in an average or net effect, the IGF-1 levels will be increased much more than in the pre-pregnant state. Now what happens to gonadotropins? The gonadotropins decrease in number, you have seen, and the major cause for reduction in number is the feedback effect, feedback by estrogen and progesterone. So these high circulating levels of estrogen and progesterone exert feedback effect on the gonadotropes, thereby reducing the FSH and LH. They are almost undetectable during pregnancy, and the gonadotropes cell number is also reduced. Now coming to the changes in HPA axis in pregnancy, the maternal ACTH, it increases 4 to 5 times during pregnancy, and during labor it increases around 15 times compared to pre-pregnancy time. And what happens to, there is something called as placental CRH. So placental CRH is another important secretory product of placenta. This placental CRH, in addition to maternal ACTH, this is placental CRH. In addition to maternal CRH, it will stimulate maternal ACTH and it will stimulate cortisol production. Cortisol is also increased. Cortisol level increases 3 times compared to the pre-pregnancy level, and this occur by around 22 to 24 weeks. So that is the clinical importance is that in patients with adrenal insufficiency who are on stable glucocorticoid replacement require an increase in dose of cortisol, probably by around 40%. So you'll need to hike the hydrocortisone dose by around 40% starting from the second trimester, late second trimester or early third trimester. You will have to increase the dose because there is physiological increase in the cortisol levels. The other change to this axis include the CBG levels increases 2 times due to the effect of estrogen. CBG levels also increase 2 times. Now, very important association between cortisol and placental CRH is that in our body, increased levels of cortisol would exert feedback inhibition on the ACTH as well as CRH, whereas high levels of maternal cortisol, it stimulates placental CRH. That is a very unique association. Cortisol stimulates placental CRH. Very important. This could be asked as a true or false question. You identify the wrong statement like that. The maternal cortisol has got a stimulatory effect on placental CRH. So what happens is a positive feedback effect. This CRH is produced by the placenta, which go and stimulate the maternal ACTH. It increases the maternal cortisol, and this maternal cortisol will further go and stimulate the placental CRH. So this runs along like a positive cascade. So coming to the changes in vasopressin levels during pregnancy, as we have seen, the posterior pituitary size reduces during pregnancy. And what happens to the thirst threshold in pregnancy as a result of hemodilution? There will be reduction in the plasma osmolality. That also causes a reduction in the thirst threshold. That means an individual who previously had thirst sensation at osmolality of around 290 milliosmol per liter now will have thirst sensation at as low as 285 or 280 milliosmol per liter. So the threshold reduction of around 10 milliosmol per liter occurs during pregnancy. And one unique feature which is associated with pregnancy is the production of a leucine aminopeptidase. Leucine aminopeptidase, which is produced from the liver. From the liver that degrades vasopressin and oxytocin. Vasopressin and oxytocin. So this can result in a condition called as gestational DI of pregnancy, gestational diabetes insipidus. Okay, so the risk of gestational diabetes insipidus increases during acute fatty liver of pregnancy and in subjects with preeclampsia. So how do you treat gestational diabetes insipidus? It is by desmopressin. Because this leucine aminopeptidase can cleave only the natural AVP, and the recombinant AVP like desmopressin is resistant to the cleavage by this enzyme produced in the liver. So important points, this usually occurs from around 20th week of gestation. The increase in this enzyme production occurs by around 20th week. Thereafter, the patient may present with a new onset polyuria, and the treatment is with desmopressin. Now, what are the changes to the thyroid gland in pregnancy? Of course, the size increases, the volume increases by around 20%, 20% increase in volume. As you know, in the first trimester, there is increased HCG level, which is produced in the placenta. This HCG has got a TSH mimetic action. TSH mimetic action, which can result in gestational thyrotoxicosis. Thereby, it increases the T4 and T3 levels and cause suppression of TSH. And the TBG increases 1.5 to 2 times the upper limit of normal, and the free hormones are normal. The total hormones are increased due to the increased TBG level, but free hormones remain normal. And regarding the thyroxine dose adjustment, you require 30 to 50% increase from the pre-pregnant dosage. From pre-pregnant dosage, you will need to increase, and this should be done as early as possible. As soon as the UPT becomes positive, you can consider increasing in the thyroxine dosage by 30 to 50%. Now, a few points on HCG. It is produced by the syncytial trophoblast, and in a normal individual, in a non-pregnant female, this HCG can be produced mainly from the pituitary. So, pituitary is the most common source for circulating HCG in a non-pregnant individual, and endometrium, testis, kidneys, all have been found to produce HCG in non-pregnant individuals, but pituitary is the most common source. The amino acid, the HCG has got an alpha and a beta chain. The alpha chain is common with the FSH, LH and TSH. It has got 92 amino acids, and beta chain has got 145 amino acids. So in total, it has got 237 amino acids. So that is about the number of amino acids in HCG. About the half-life, it is around 24 to 36 hours. It has got a long half-life of 24 to 36 hours compared to TSH, which has a half-life of only 40 to 50 minutes. And sources we have already discussed. Pituitary is the most common source. Now, what are the changes to adrenal gland during pregnancy? Cortisol, we have already learned, it increases 3 times. 3 times increases. The CBG increases 2 times. 2-fold elevation in CBG and 3-fold elevation in cortisol, and it occurs mainly from the 22 to 24 weeks of gestation when there is a sudden surge in the placental CRH production. Aldosterone, again, there is a 3 to 5 times elevation in aldosterone level as well as renin level. About DHEAs, actually the DHEAs production is increased in the fetus. DHEAs production increase in the fetus, but in the mother, this DHEAs is converted into 16 hydroxy DHEAs and is channeled to estrogen synthesis, estrogen production. So the DHEAs levels actually are low compared to pre-pregnant levels. It is not because that their production is reduced, their production is actually increased, but there is increased utilization for production of estrogen. So the ambient levels of DHEAs will be reduced compared to the pre-pregnant levels. And catecholamines levels, the metanephrine as well as the adrenaline, noradrenaline levels remain normal. This was a previous question. regarding the changes in the adrenal axis. The catecholamine levels are essentially normal. The DHEAS levels reduces, the aldosterone level increases, the cortisol level increases. Now, about the bone mineral metabolism in pregnancy, calcium, it is in the third trimester that there is a large transfer of calcium and vitamin D from the mother to the fetus. Around 30 grams of calcium, 30 gram of calcium is transferred from the mother to the fetus, and the most important mediator of this transplacental calcium transfer is the PTHRP. So, PTHRP is an important mediator of the transplacental calcium transport to the fetus. And what happens to PTH levels? PTH levels remain essentially normal. The vitamin D levels are increased, both the 25-hydroxy as well as 125-dihydroxy vitamin D3, because the placenta itself synthesizes, the placenta produces 125-dihydroxy D3. So, therefore, there is increased levels of both 25-hydroxy and 125-dihydroxy vitamin D3. Also, these increased levels of growth hormone, estrogen and prolactin all will stimulate the 1-alpha hydroxylase action, which also result in the increased generation of calcitriol. And PTHRP, again, it increases. It has two main roles, one in the calcium transport across placenta and also the calcium level regulation in breast milk. And the excessive levels of PTHRP in the mother has been found to be associated with reduced bone mineral density and increased risk of fractures, because more and more calcium will be driven out of the maternal bone into the maternal circulation and will be transmitted to the fetus. This is what we call as gestational, or sometimes it can occur during lactation, then we call it as lactational osteoporosis. So, the mediator of gestational or lactational osteoporosis is PTH related peptide or protein, and the most common presentation of this gestational osteoporosis is hip fracture. They would present with hip fracture. So, those are the important things. Now, what about the glucose and insulin metabolism during pregnancy? There is increase in the beta cell mass. The beta cell number increases, but consequently the insulin resistance also increases. The insulin resistance also increases. Why is it so? Because of the increased levels of growth hormone variant from the placenta as well as the human placental lactogen. So, this human placental lactogen, what it does is that it causes increased lipolysis from the maternal adipose tissue. Therefore, there is increased free fatty acids. And why there is excessive lipolysis by the by the HPL is that when the maternal concentration of free fatty acid increases, the mother will be forced to use fatty acids more as the energy substrate, due to which the glucose and the essential amino acids can be transferred to the fetus. This is actually an adaptive mechanism so as to ensure the adequate supply of glucose as well as the amino acids to the fetus. So, because there is excessive circulating concentration of free fatty acids in the mother, that will induce insulin resistance. That is why insulin resistance is increasing, but the beta cell proliferation is also there. Therefore, the insulin production during pregnancy increases. Both insulin production as well as insulin resistance increases. The role of HPL we have already learned. The HPL levels start increasing by around 22 to 24 weeks, and it peaks by around 32 to 34 weeks. Peaks by 32 to 34 weeks. And what about glycemia in pregnancy? In the early pregnancy, the glucose level actually reduces. Why? Because there is increased transplacental transfer of glucose from the mother to the fetus. So, the maternal glucose levels would decrease. But during the late pregnancy, especially on the second half of pregnancy, there is increased insulin resistance induced by this growth hormone variant as well as HPL. It will result in the elevation in glucose level. The glucose intolerance occurs in the late pregnancy. So, that is the changes occurring to the glucose and insulin metabolism in pregnancy. The insulin production increases, the beta cell mass increases, but the insulin resistance also increases due to the effect of counter-regulatory hormones. and the glucose levels, ambient glucose levels reduces in the early pregnancy, and towards the second half of pregnancy, they would experience more insulin resistance and worsening of glycemic control. Now, a few words on the endocrinology of parturition. You know that the estrogen and progesterone levels are increased throughout pregnancy, and progesterone has got a strong tocolytic action. That means it prevents the uterine contraction, thereby resulting in the prevention of premature labor. That is an important function of progesterone. So when the parturition is supposedly going to happen, they would have increased uterine contraction. So what are the mediators of increased uterine contraction? One, there is increased CRH and increased urocortin. Increased CRH and increased urocortin levels, this will result in increased PGE1, increased PGF2 alpha, and reduced PGE2 and reduced PGI2, and also increased oxytocin. So these are the changes occurring during parturition, which results in increased uterine contraction. So you have to remember that PGE1 is a pro-contractile agent, PGF2 alpha is also pro-contractile agent, whereas PGE2 and PGI2, which is the prostacyclin, they both has got a tocolytic action. That means they would reduce uterine contraction. So when the parturition nears, these hormonal changes occurring, resulting in the increase or the tilting of the balance towards the pro-contractile agents, thereby causing initiation and further maintenance. And the most important hormone maintaining the uterine contraction is the increased levels of oxytocin.